Vulvovaginal candidiasis, genital thrush, is a symptomatic inflammation of the vagina and/or vulva caused by a superficial fungal infection, usually yeasts that belong to the genus Candida. Candida yeasts are part of the normal flora of the mucous membranes of the female genital tract, but overgrowth can cause infection. It typically causes symptoms of vulval or vaginal itch and irritation, and a non-offensive vaginal discharge. Recurrent infection describes 4 or more symptomatic episodes in 1 year, with at least 2 episodes confirmed by microscopy or culture. When symptomatic, at least 1 must be culture. Candida albicans is the most common and accounts for 80 to 89% of cases. Glabrata is responsible for a further 5%. C. tropicalis, C. parapsilosis, C. cruzi, C. kefir, C. guillermondii, and Saccharomyces cerevisiae account for most of the remaining cases. Risk factors. The risk factors for developing recurrent vulvovaginal candidiasis are uncertain, and women may have no obvious predisposing or underlying condition. Possible factors include non-compliance with treatment, recent antibiotic use within 3 months, causing a change in the vaginal flora, local irritants such as soaps, shampoos, shower gels. Douching can predispose or exacerbate symptomatic vulvovaginal candidiasis, persistent infection with Candida species infection with non-albicans Candida species azole resist, and Candida species such as Candida glab. Uncontrolled diabetes mellitus and other causes of immunosuppression such as HIV infection and long-term corticosteroid use. Women with HIV may have more frequent or persistent infection if they are immunosuppressed. Women with HIV have increased colonization rates with Candida species and possible increased rates of symptomatic infection. But disease severity and recurrence rates are not increased. Endogenous and exogenous estrogen up to 20% of women of reproductive age may be colonized with asymptomatic Candida species. Candida species is typically found in pubertal, post-pubertal, and not prepubertal females. Increases in endogenous and exogenous estrogen, such as pregnancy, the combined oral contraceptive pill, and hormone replacement therapy, may cause overgrowth and symptomatic infection. Asymptomatic colonization and symptomatic Candida infection is more common in pregnancy. There is no evidence of association with low birth weight or preterm delivery. There is inconsistent, mixed evidence of a link between combined oral contraceptive pill, intrauterine contraceptive devices, and the intrauterine system and the development of vulvovaginal candidiasis in the literature. Possible complications of vulvovaginal candidiasis include treatment failure. Occurs in up to 10 to 20% of women receiving imidazole treatment for acute infection. Recurrent infection. Women may have a poor or partial response to therapy with persistence of symptoms between treatments. Reduced quality of life and psychosexual difficulties, including embarrassment, reduced libido and arousal, may affect women who have recurrent infection. Canidobalanitis may occur rarely in male partners of women with vulvovaginal candidiasis. This typically presents with erythematous areas on the glands of the penis, pruritus, and/or irritation. A retrospective observational study of women with Candida albicans recurrent vulvovaginal candidiasis 6 months after completion of maintenance fluconazole therapy and 201 found that 19.2% of women reported no further episodes of infection. 17.5% of women reported less than 3 episodes a year. 63.3% of women reported more than 3 episodes a year. Diagnosis. If a woman has suspected vulvovaginal candidiasis, ask about the duration and severity of symptoms, such as vulval or vaginal itching, often the defining symptom, vulval or vaginal soreness and irritation, vaginal discharge, usually white, cheese-like, and non-malodorous, Superficial dyspareunia, dysuria, pain or discomfort during urination. The frequency of symptoms, an isolated episode, or recurrent symptoms, or treatment failure. Any risk factors for candidiasis. Any risk factors for a sexually transmitted infection. STI, if appropriate. Any treatments tried, including over-the-counter treatments, risk of pregnancy and contraceptive use, were other symptoms which may indicate an alternative or additional diagnosis. Foul smelling or purulent discharge could indicate a bacterial infection. Urinary frequency. Urinary frequency and urgency could indicate a urinary tract infection or sexually transmitted infection. Abnormal vaginal bleeding could indicate an STI or gynecological cancer. Other recurrent infections may indicate possible immunosuppression. Examination. Consider performing an examination of the external genitalia if there is suspected acute vulvovaginal candidiasis, and routinely offer an examination if there is treatment failure or suspected recurrent infection to exclude an alternative or additional diagnosis. Note: external genital examination may be normal. Signs of severe vulvovaginal candidiasis include erythema, usually localized to the vagina and vulva, but may extend to the labia majora and perineum, vaginal fissuring and/or oedema. Satellite lesions, rare, may indicate other fungal conditions or herpes simplex virus, HSV, infection, or vulval excoriation. Investigations. Investigations are not routinely needed if clinical features suggest acute vulvovaginal candidiasis. Consider investigations to confirm the diagnosis and/or exclude an alternative diagnosis if there is diagnostic uncertainty or persistent or recurrent symptoms, depending on clinical judgment. Note: a self-collected low vulvovaginal swab, LVs, may be appropriate if examination of the external genitalia is not possible or needed. Consider a high vaginal swab, HVSAS, of vaginal secretions for microscopy first line for suspected acute vulvovaginal candidiasis. Arrange a HVS of vaginal secretions for culture for suspected recurrent vulvovaginal candidiasis. This may identify Candida albicans, non-albicans Candida species, or an additional infection. If there is a poor or partial response to maintenance therapy, request culture with full speciation and sensitivity testing. Consider arranging a self-collected vaginal swab if initial results are negative. Consider vaginal pH testing of secretions, but this is not essential to make a diagnosis of Candida infection. Consider a midstream sample of urine, if a UTI is suspected. Consider an HbA1c test to exclude diabetes mellitus in severe or recurrent infection. Consider a full blood count and serum ferritin level to exclude iron deficiency anemia. Consider STI screening if the woman is concerned or at risk, or if there are clinical features suggesting an STI. Chlamydia, uncomplicated genital, gonorrhea, herpes simplex, genital. HIV infection and AIDS, syphilis, trichomoniasis. Differential diagnosis. Alternative or additional conditions which may present similarly to vulvovaginal candidiasis include bacterial vaginosis, common, itch is not usually prominent, and discharge is usually white, homogeneous, and malodorous. Trichomoniasis, associated with itch and vaginal discharge, which is usually profuse, frothy, gray-green, and malodorous. Chlamydia can cause vaginal discharge and dysuria, but does not usually present with itch. Gonorrhea rarely presents with itch, but is associated with pain and a purulent cervical discharge. Genital herpes may present with acute vulval pain, redness, itch, and ulceration. Discharge is uncommon. Non-infective conditions, such as normal physiological discharge, typically is cyclical, with no associated itch, pain, or malodor. may increase during puberty and pregnancy. Vulval skin conditions, vulval eczema, contact dermatitis to chemicals or latex, lichen simplex chronicus, lichen sclerosus, lichen planus, and psoriasis may cause itch. Atrophic vaginitis may cause vaginal discharge in postmenopausal women. Vulvodynia, vulval discomfort, often at the introitus with focal tenderness on examination. Cytolytic vaginitis can also present with cheese-like vaginal discharge and itch, but microscopy and fungal culture is negative. Foreign body, such as retained tampon, may cause malodorous vaginal discharge. Mechanical irritation, for example due to lack of lubrication. Gynecological malignancy, malignancy of the vulva, vagina, cervix, or uterus can cause vaginal discharge. Management. Affected women may have a good or complete response to therapy and are asymptomatic between episodes, or poor or partial response to therapy with persistence of symptoms between treatments. Treatment failure is defined as failure of symptoms to resolve within 7 to 14 days of treatment. Treatment of acute infection. If a woman presents with an episode of acute vulvovaginal candidiasis, advise on self-management measures to provide symptom relief. Use simple emollients as a soap substitute to wash and/or moisturize the vulval area. Avoid contact with potentially irritant soap, shampoo, bubble bath, or shower gels, wipes, and daily or intermenstrual feminine hygiene pad products. Avoid vaginal douching. Avoid wearing tight-fitting and/or non-absorbent clothing, which may irritate the area. Avoid use of complementary therapies such as application of yogurt, topical or oral probiotics, and tea tree or other essential oils. If a woman has uncontrolled diabetes mellitus or is otherwise immunocompromised, optimize management of any underlying conditions causing immunocompromise if possible. Advise on antifungal drug treatment options and preparations, depending on the woman's age, comorbidities, personal preference, and drug cautions and contraindications. Advise fluconazole 150 mg oral capsule as a single dose first line. Advise clotrimazole 500 mg intravaginal pessary as a single dose if oral therapy is contraindicated. Advise that topical imidazole preparations may damage latex condoms and diaphragms. If there are vulval symptoms, consider advising on use of a topical imidazole in addition to an oral or intravaginal antifungal. Options include clotrimazole 1% or 2% cream applied 2-3 times a day. Advise that oral fluconazole, intravaginal clotrimazole, and topical clotrimazole can be bought over the counter. Advise that topical imidazole preparations may damage latex condoms and diaphragms. If there are signs of severe infection, advise to repeat antifungal drug treatment after 72 hours. Prescribe fluconazole 150 mg oral capsule on day 1 and 4 first line. Arrange follow-up if symptoms have not resolved within 7 to 14 days or if symptoms are recurrent. Advise that follow-up and test of cure are not necessary if symptoms have resolved. Do not routinely treat an asymptomatic male sexual partner. If first-line oral azole or intravaginal imidazole therapy is contraindicated or not tolerated for acute infection, alternative treatment regimens are greater than intravaginal creams, clotrimazole 10% cream. 5. If first-line oral azole or intravaginal imidazole therapy is contraindicated or not tolerated for acute infection, alternative treatment regimens are intravaginal creams, clotrimazole 10% cream, 5 grams intravaginally as a single dose at night. Miconazole 2% cream, 5 grams intravaginally once at night for 7 nights. Intravaginal pessaries, clotrimazole 200 milligrams pessaries, 3 pessaries. Insert 1 pessary intravaginally once at night for 3 nights. Iconazole nitrate 150 milligrams single dose pessary for adults and children aged over 16 years. Insert 1 pessary intravaginally once at night as a single dose. For severe infection, clotrimazole 500 milligrams pessary, 2 pessaries. Insert 1 pessary intravaginally on day 1 and 4. Miconazole nitrate 1-2 grams single-dose vaginal capsule for adults aged 18 years and older. Insert 1 capsule intravaginally once at night on day 1 and 4. For breastfeeding women, do not prescribe an oral antifungal. Topical imidazoles are a safe and equally effective alternative. For girls aged 12-15 years, consider prescribing topical clotrimazole, 1% or 2%, applied 2-3 times a day, or seek specialist advice. Do not prescribe an intravaginal or oral antifungal. Treatment failure of acute vulvovaginal candidiasis. If a woman has acute vulvovaginal candidiasis, which has not responded to initial treatment within 7-14 days, check that initial treatment was used as recommended. Be aware that topical treatments can cause vulvovaginal irritation, which may be mistaken for treatment failure. Reassess for risk factors for persistent or recurrent infection, and manage appropriately. Arrange an examination of the external genitalia, if not already performed, with high vaginal swab, and arrange other investigations to assess for an alternative or additional diagnosis, depending on clinical judgment. Treat any ongoing infection, depending on the HVS result. If there has been poor compliance with initial treatment, prescribe an alternative preparation. For example, prescribe oral treatment instead of intravaginal treatment. Reinforce self-management advice for symptom relief. Arrange specialist referral or seek specialist advice, depending on clinical judgment. If an affected young person is aged 12 to 15, why? There is uncertainty about the diagnosis. Symptoms are not improving and treatment failure is unexplained. Symptoms persist after a second course of antifungal treatment. The woman has uncontrolled diabetes and treatment failure. Management of recurrent infection. If a woman presents with recurrent vulvovaginal candidiasis, reinforce advice on self-management measures to provide symptom relief. Reassess for risk factors for persistent or recurrent infection, and manage appropriately. Arrange an examination of the external genitalia with high vaginal swab, and arrange other investigations to assess for an alternative or additional diagnosis, depending on clinical judgment. Offer an induction regimen immediately followed by maintenance treatment, the drug treatment and preparation depending on the woman's age, comorbidities, and personal preference, and drug cautions and contraindications. For induction, prescribe 3 doses of oral fluconazole 150 milligrams to be taken every 72 hours, first line. For maintenance, prescribe oral fluconazole 150 milligrams once a week for 6 months, first line. Note: routine use of a topical imidazole, in addition to an oral or intravaginal antifungal for vulval symptoms, is not recommended. Arrange follow-up if there is a poor or partial response to maintenance treatment. Do not routinely treat an asymptomatic male sexual partner. Alternative treatment regimens if first-line oral azole therapy is contraindicated or not tolerated for recurrent infection. Induction therapy, topical imidazole therapy, such as clotrimazole 500 milligrams intravaginal pessary, can be increased to 7 to 14 days, depending on symptom response. See the section on alternative treatment regimens in the Induction therapy, topical imidazole therapy, such as clotrimazole 500 milligrams intravaginal pessary, can be increased to 7 to 14 days, depending on symptom response. Maintenance therapy, clotrimazole 500 milligrams pessary, inserted intravaginally once a week for 6 months, or oral itraconazole 50-100 milligrams daily for 6 months. For breastfeeding women, do not prescribe oral antifungal treatment. Intravaginal clotrimazole may be prescribed for induction and maintenance therapy as a safe and effective alternative. Follow-up. If a woman has completed an induction and maintenance regimen of treatment for recurrent vulvovaginal candidiasis, if there are recurrent symptoms between maintenance treatment doses, options include oral fluconazole 150 milligrams twice weekly instead of once a week, or considering the use of cetirizine 10 milligrams once daily for 6 months, particularly if there is a history of allergy, off-label indication. If there is a poor or partial response to maintenance therapy, check concordance with therapy. Arrange a high vaginal swab and request culture with full speciation and sensitivity testing, if not already requested, and treat accordingly. If HVS culture is negative and symptoms persist, consider assessment for an alternative diagnosis. If a non-albicans candida species or a zoll-resistant candida is identified, seek specialist advice. If there are infrequent further sporadic episodes of vulvovaginal candidiasis, treat each episode as an acute infection. If there is further recurrent vulvovaginal candidiasis, consider the use of a repeat induction and maintenance treatment regimen if clinically indicated. Referral. Arrange specialist referral or seek specialist advice, depending on clinical judgment, if an affected young person is aged 12 to 15 years. There is uncertainty about the diagnosis. A non-albicans candida species or a zoll-resistant candida is identified. A woman has uncontrolled diabetes and recurrent infection. Treatment in pregnancy. If a woman is pregnant or at risk of pregnancy and presents with vulvovaginal candidiasis, advise on self-management measures to provide symptom relief. Use simple emollients as a soap substitute to wash and/or moisturize the vulval area. Avoid contact with potentially irritant soap, shampoo, bubble bath, or shower gels, wipes, and daily or intermenstrual feminine hygiene pad products. Avoid vaginal douching. Avoid wearing tight-fitting and/or non-absorbent clothing, which may irritate the area. Avoid use of complementary therapies such as application of yogurt, topical or oral probiotics, and tea tree or other essential oils. Advise on antifungal drug treatment options and preparations for symptomatic acute infection, depending on the woman's age, comorbidities, personal preference, and drug cautions and contraindications. Prescribe clotrimazole pessary 500 mg intravaginally at night for up to 7 consecutive nights first line, if aged 16 years and older. Offer an induction regimen immediately followed by maintenance treatment for recurrent infection. For induction, prescribe topical imidazole therapy, such as clotrimazole pessary 500 mg intravaginally at night, if aged 16 years and older, for 10-14 days according to symptom response. For maintenance, prescribe 1 clotrimazole pessary 500 mg intravaginally at night, once a week for 6 months, if aged 16 years and older. If there are vulval symptoms, consider prescribing a topical imidazole in addition to an intravaginal antifungal. Options include clotrimazole 1% or 2% cream applied 2-3 times a day. Arrange follow-up if symptoms have not resolved within 7-14 days for acute infection. Advise that follow-up and test of cure are not necessary if symptoms have resolved. Do not routinely treat an asymptomatic male sexual partner. Alternative treatment regimens if first-line therapy is contraindicated or not tolerated for acute infection in pregnancy. Alternative treatment regimens are clotrimazole vaginal cream, 10% 5 grams, intravaginally at night for up to 7 consecutive nights. Clotrimazole pessary 200 mg intravaginally at night for up to 7 consecutive nights. Iconazole pessary 150 mg intravaginally at night for up to 7 consecutive nights. Miconazole capsule 1,000, 200 mg or 400 mg intravaginally at night for up to 7 consecutive nights. Miconazole vaginal cream, 2%, 5 grams intravaginally at night for 7 consecutive nights. Treatment failure in pregnancy if a pregnant woman has acute vulvovaginal candidiasis, which has not responded to initial treatment within 7-14 days. Check that initial treatment was used as recommended. Be aware that topical treatments can cause vulvovaginal irritation, which may be mistaken for treatment failure. Reassess for risk factors for persistent or recurrent infection and manage appropriately. Arrange an examination of the external genitalia, if not already performed, with high vaginal swab HVS, and arrange other investigations to assess for an alternative or additional diagnosis, depending on clinical judgment. Treat any ongoing infection, depending on the HVS result. Reinforce self-management advice for symptom relief. Referral, arrange specialist referral, or seek specialist advice, depending on clinical judgment, if an affected young person is aged 13-15 years. There is uncertainty about the diagnosis. Symptoms are not improving and treatment failure is unexplained. Symptoms persist after a second course of antifungal treatment. A non-albicans candida species, or